Hi. Good afternoon. As you can see, my talk is called Walking and Talking with Rett Syndrome. I don't know if we'll get to the talking part, so I might not be talking on talking with Rett Syndrome today. So this is why I have those brackets, but let's see if the time permits. So what I'm going to talk about is the UPSI. It's a new device. I'm going to present two case studies, one with a girl with Rett syndrome and the other with a girl with CDKL5. I'm going to present a new study. It's of two of my students. It's just been finished two weeks ago, so you're the first to actually see the results. And then I'm going to present three different direction of regaining and enhancing walking in Rett syndrome. One will describe an intensive program that got a woman who was sitting for 5 years in a wheelchair to walk again. The other is using applied behavior analysis to enhance walking in a girl that was able to walk but was actively avoiding walking. And the third is the use of Therapies with individuals with Rett syndrome, because I've been, in many places, I've been asked if Therapies are efficient for girls with Rett syndrome. And I kept these insights from talks with Rett syndrome, preserved speech variant, but I don't know if we'll get there if we have the time. So first thing first, I want to say thank you to Ursef, especially for Paige, for having me here. It was a last-minute call, and thank you, and for this amazing reward. And for Pamela Diener, who was flexible enough, because it was supposed to be her talk, and she was, thank you, she was flexible enough to give me this place and time. To the Lucky Company, they are the ones who are, they're called Firefly outside, that you know, I have to, full disclosure, they are the one who paid for my trip here, but I'm not here as an employee of Lecky. I'm here as an enthusiastic physiotherapist, and you're going to see why in a few minutes. I want to say thank you for the children with Rett syndrome, because, you know, you say that necessity is the mother of all inventions, and the challenges that children with Rett always put for the therapist to solve I think is what evolved me and made me a better physiotherapist all through those years. And I've been working with girls with Rett syndrome for 22 years. Both as a researcher, as part of the Israeli Rett syndrome national evaluation team, and also as a therapist working with 12 girls with Rett syndrome, one boy with Rett syndrome, and one girl with CDKL5 on a weekly basis. And this is my private clinic. And to the parents of the families, because they're always willing to participate in all those research projects that I initiate and agree for the data to be published and everything. And to my co-workers, which I will talk about when we get to each project. So first I'm going to present the use of the UPSI, and I'm talking here on behalf of Nava Galkop, which is a physiotherapist from Jerusalem, and Debbie El-Natan, which is actually, she's the mother of a child with cerebral palsy from Jerusalem, and she invented the UPSI. She called it double walker. Okay, so first things first, we have to ask, what is the importance of walking for young children? And the thing is that when the child is born, the hip joint is not completely grown up, okay? It's not mature. You have to put a lot of pressure and movement on it in order for the two parts, the pelvis and the femur, to join together. So it builds up the hip joint, and we know that some girls with Rett syndrome have hip instability, or it improves bone density, and we know that girls with Rett syndrome might suffer from osteoporosis or osteopnea, so this is good for us. It improves joint range of motion and prevents reduction in joint range of motion. Many of the girls who do not walk are actually, I have to have a chair. They sit for a long duration of the day, and eventually when you sit for a long duration of the day, these muscles here are shortening, okay? So the fact that you get up and you move actually preserves your range of motion in the hip and the knees. It prevents hip dislocation. Again, when you sit down, okay, hip dislocation occurs when you have flexion, adduction of the hip, and internal rotation, okay? And then the hip is sliding backwards. Now, what helps as well is the glutes. When you sit down for a long duration of time, the glutes are becoming longer, okay, and weaker, and therefore they're not here to support. So if you're walking, then you build up your glutes, and you're not always in this flex position, so you're far away from the dislocation, and you have support for the hip joint not to go out of place. Walking reduces spasticity, at least when you're walking, not for long durations, and it improves internal organs functioning due to improved circulation. So we know that both girls with Rett syndrome and CDKL5 have constipational problems, intestinal problems. So if we walk, we get circulation inside, so we get less constipation. But these are all physical and physiological changes. But the thing is that if we look at a normal child developing, you know, they're always running around the house, you know, they're exploring everything, they're taking the pots out of the kitchen cupboard, and they're taking the fruits out of the fruit basket, and, you know, this is actually what helps them to develop problem solving, to develop their cognition, to develop their spatial orientation. So without moving around, we actually miss a lot of development, not only in the physical concept. Okay, so the next question that we need to ask is, okay, so if my child doesn't walk, so if I'm going to practice walking, is it going to change anything? Well, studies from regular children and from children with Down syndrome actually suggest that if you do walking exercises, it improves stepping, it improves the walking pattern, and enhance acquisition of walking ability. But if we look, this is a research project I did 2004, and actually if Pam was talking about an enriched environment, we had 4 girls walking on a treadmill for 2 months every day, and their function improved and their physical fitness improved correlatively. So they were fitter and functioned better because of those 2-month daily training. So I want to present the APSI as a means to reduce fear of movement in the child with Rett syndrome. It's not exactly what I've talked about so far, about improving walking, but you'll see what I'm talking about. So in order to go into this subject of fear of movement, we have to go back a bit and get some background information. So one of the many characteristics of Rett syndrome is fear of movement, especially when initiated by an external facilitator. So when the physiotherapist comes and we move the child, and you see all those reactions, okay? And this fear of movement was mostly associated with the vestibular system. Okay, I don't know if you read the book by Barbro Lindberg. She's a teacher from Sweden, and it's a book called Understanding Rett Syndrome. It's a very nice book. If you haven't read it already, then get it and read it. But the thing is, I have a supportive audience. The thing is that we suspected that the fear of movement in the individual with Rett syndrome actually originated from dysfunctional proprioceptive system. So let's look at the difference. The vestibular system is inside the inner ear, okay, in here, and it actually gives us information about movement of the head and direction of movement of the head. We have another system, the proprioceptive system. Okay, and this it's an information that comes from the muscles and the joint, and it actually gives us information on how our body is in space. For instance, I can touch my nose with the tip of my finger without seeing the tip of my finger and my nose, because the proprioceptive system actually tells me where the different parts of my body are. Okay, so this is research done by Shani and Batzion, two of my students. And vestibular, these are vestibular activities, okay? A lot of swinging about. I don't know this man. I just took this photograph off the internet. I have no connection with him. Okay, but he's doing intensive vestibular input to his child. I don't know what the consequences are, as Pam said. Too much, maybe too much is. I mean, and a lot might be sometimes too much. But okay, I'm not responsible for this one. And proprioceptive is something more. Okay, you see, it's jumping around, it's moving around. It's not just getting your head twisted. Okay, so we checked out 10 children. Okay, this is what we used. We wanted to see what was causing the fear of movement in girls with Rett syndrome. So we took a vestibular plate, we mounted a video camera on it, and it was filming the faces of the girls. Of course, inside it was padded with blankets and stuff. It wasn't, they didn't lie on the, and this is what we saw, okay? As you can see, this is, sorry. To get the vestibular input, the child would be inside the plate, and I would rotate the plate. So the child was resting, she wasn't moving, and only the head was moving from side to side, so you get a vestibular input. And proprioceptive, I held the plate so it would move, okay, and then I moved the hands and the legs of the children. And I'm talking about very gentle moves. It's not, not something very wild. And you can see here, this is the response for the vestibular, okay? I mean, okay, I can deal with this, and this is, oh my God, leave me alone. With the proprioceptive input, and again, this is nonchalant, oh, let's go to something else. This is, I'm enjoying myself, and this is kind of, you can read it yourself. Vestibular is okay, proprioceptive is not so much okay. Vestibular, I'm laughing, proprioceptive, ooh, what's that? But we actually used other scales than just ooh and wow and I don't like it. We used this, two scales. This is called the PADS, the Pain and Discomfort Scale, and the FACS, Facial Action Coding System. It's two scales that actually measure human behavior and interpret what you see. And we got very negative, high negative responses on the proprioceptive and much on both scales. So the difference was statistically significant. So this actually suggested that fear of movement in individuals with Rett syndrome stems from misinterpretation of messages from the proprioceptive system. Therefore, activation of body and limbs is required from a young age. So why diapsy? First of all, it enables practicing walking and change in walking patterns, as we've seen from the other experiments. It enables weight bearing and weight shifts, which is necessary for walking. It encourages movement of trunk and limbs, and this I highlighted this one because it's actually what I've been talking about proprioceptive system. It's accessible in different environments. You can take the child, you can go up and down the stairs, you can go for shopping malls, you can go to parks, and not just when this child is sitting in his stroller or his wheelchair, but when she's walking around. It enables taking part in different activities. As I've said before, a child without motor disabilities moving around the house by itself and exploring the environment. A child with disability who can't move actually does not have the same chances. But maybe the most important thing is that practice is meaningful and associated with high level of motivation. Okay, and this, I highlighted this one as well. What happens is we are all very good-hearted, okay, and full of good intentions. So we come and we try to move the child with Rett syndrome, and she has a fear of movement, so she's going like this, and all of us are saying, oh, the poor child, she's suffering so much. Let's not, just keep her not moving. And what this does, if you have listened to Pam's lecture, when we don't have input, we lose connections in the neural system. So if we get the child her way, we get her to sit down and be less active, then eventually we get her to be more afraid of movement, and then we do less because she's so afraid, and then she gets even more afraid, and we get a child who is eventually very stiff and doesn't want to move. And so the whole idea about using the APSI was that this is an activity that the child is doing with their parents. Okay, so it's now movement is not something that a physiotherapist comes and moves you around. Your parent is coming, your parent that you're loving very much is coming, and you're dancing with him, you're moving with him. Suddenly movement is associated with meaningful and positive experiences, and this is what the idea was, and it's easy to handle. So I want to present the first case study. When we started, she was 3. She just had her 4th birthday a week ago. And from day one, when I started treating her, she has been showing extreme fear of movement, fixating her limbs to prevent them from moving. Now, I want to show you something now. In order for us to move, we have to stabilize our body. Okay, if I want to walk, I'm stabilizing the left part of my body, and I'm moving the right side. Okay, if I want to take this microphone, I'm stabilizing my trunk and I'm reaching with the hand. If you have a fear of movement, what you do, you don't stabilize, you fixate. Okay, you just hold everything like this. But now, this is not very functional. I can't reach, I can't move, I can't do anything. So what children with fear of movement are doing, they're fixating very strongly, so movement will not occur, okay? And we need to take this fixating and change it into a more normal way of working and functioning with stabilization. Okay, so without freeing her from this stagnating fear, she will never cope with movement. So as long as she's holding so strongly, she will never be able to actually move and function because she's stuck in her fear. So therefore, the beginning of each therapy session is a 20 minutes body movement section, which is aimed at preparing her for the session. So this is what I do. So you have to remember, first of all, I want you to see how long it takes me to flex her knee, okay? Okay. This is the first movement. Flexing her knee takes about 30 seconds or something. Just, she's on her back, she's watching television, and think about it. The physiotherapy session is 45 minutes, and 20 minutes out of that I'm spending on just getting her ready to be moved. So that's a lot of time. This is kind of the 3rd time I get to the hands, because at the beginning it's very mild movements, very slow movement, and now this is kind of her brother is trying to watch television. I'm in his way all the time, so he's... Okay, and this is kind of towards the end. I can get some bicycle movements to the legs. I can get them moving forward, backwards, from side to side. Okay, now everything is becoming easier. So this is after 20 minutes. I've shortened it down to 1.5 minutes, but this is after 20 minutes of doing that, and then we get to standing on all fours, so she gets some proprioceptive input from her from her body who is moving, and then we get to a standing position, and this is actually where I want her to work, okay? Okay, and this is how the sessions looked at the beginning. Okay, this is November. You see her face. You see how much she is afraid. You see that she's always putting her hands inside the mouth. She's trying to catch her shirt. Okay, she's trying to catch her shirt as if it will help her not to fall. And all I'm asking her to do is stand. Okay, there's not a lot of movement involved. All I want her to do is just stand and hold her body without fixating it, just slowly moving it from side to side and freeing it. And this is how her mother used the UPSI. Can you raise the volume, please? This is without the UPSI, so she really needs to move her legs. This is the first step they take with the UPSI, and she's still rigid at the legs, so her mother really need to start moving her legs with the hands. See a lot of positive input. This is how you make it. Maybe you should call it the instrument that will make your brother crawl. This is something that is very trivial for a regular child. I mean, going into the fruit basket and getting to know the bananas and the potatoes and the oranges is something every child does. But a child with a motor disability might know the living room, his room, and the bathroom, and they don't usually go around the house. So and showing her the bananas, the avocados, the potatoes. There he comes again. Now, if you look here, this is a more advanced stage, and you remember at first she had to actually move the child's legs in order to get some movement, but here, what she's doing is she's taking her leg backwards and she's waiting for the child to start the movement. And the moment she feels that the child is moving, look who's moving first here. Okay, the child was actually moving her legs first, and she was coming along with her. So the child is showing initiation of movement in those legs that was previously were held so strongly. Okay. So after the use of the APSI, we got the preparation of therapy, which you've seen before, reduced to 10 minutes instead of 20 minutes. The girl is using stabilization technique instead of fixating her whole body, and there's less stress, and she's smiling and even laughing during therapy. So, and the level of therapy, like the demands that I put on her during therapy are much higher than before. Okay, so therefore, I think that the APSI, okay, I can't, she's having once a week physiotherapy by me, and once a week from the physiotherapist at school, and occupational therapy and hydrotherapy and hypotherapy. So I can't, separate each of those interventions and say the APSI did it all. But I think that the APSI enabled positive elements to be associated with movement for this child, and her body reactions are much more in sync with daily function, instead of being so stuck and so holding everything together. She's now much more, she's moving much more freely than before, and we got all those secondary gains as well. The second girl I want to show you is a girl with CDKL5. Now this is the girl, she's very beautiful. And she is suffering from numerous and intense seizures throughout the day from a young age. I mean, when I started treating her, she could have like 3 or 4 seizures in one session. Like in 45 minutes when I was treating her, she would have like 3 or 4 seizures. Therefore, she is always on the mattress because everybody is afraid she's going to have a seizure and fall down from a standing frame or from a chair or anything. And she adapted to this situation and does not try to crawl or push to standing or walking, despite the fact that she has no physical limitations. I mean, her muscle tone is quite within the norm. She has range of motion in her hands, and trunk is almost complete, but she's always like this. She's just lying on the ground most of the day. Even at the day center, they are afraid to move her too much. So using the APSI within physiotherapy sessions is a possibility, because I can practice walking up and down the stairs. I can walk with her. I can explore different aspects of her house. I can dance with her, practice jumping, which is actually proprioceptive input. We can do it quickly or we can do it slowly, so she can get more input out of it. It's basically the same things that the mother did with the other child with Rett syndrome without the baby after us. So just okay, so she is never in this upright position. She never experiences this kind of movement. So I'm telling her to sit down. Despite the fact that she is not moving a lot, this child is a Zumba fan. She's the only. I've tried different kinds of music with her, and the music that she loves the most is music songs. I think because her mother is actually doing Zumba, but this is what she reacts to. This is her favorite music. Oops. Okay. No, actually, she's usually doing this. No, she can hold her head upright. Yeah. Okay. So the next, this I want to present another research done by two of my students, Talia and Mayan, about losing and regaining independent walking in girls with Rett syndrome. So we know that Rett syndrome is described in the literature as having 4 stages, with the 4th stage, late motor deterioration, describing loss of ambulation after it was acquired. But we also have in the literature 3 case studies describing women with Rett syndrome who have regained walking ability after 5 or 12 or even 23 years in a wheelchair. This last one, okay, this was described by a Norwegian physiotherapist. It's about a woman who, at the age of 20, her mother died, so she was put in a residential setting, and she stopped walking. My guess it was because of depression, but she lost her walking, and 23 years later comes a physiotherapist and says this woman can actually walk, and he gets her off the wheelchair, and she kept walking for I think 10 more years until she passed away. So it is possible to get women with Rett syndrome, some of them, not all of them, to get women with Rett syndrome who are already using a wheelchair out of the wheelchair. And also, my clinical experience suggests that there are many who lose and regain walking ability, yet this phenomena is not mentioned in the literature. Actually, what initiated this research was when the Rett syndrome, Israeli National Rett Syndrome Evaluation Team, when we got to a school and we saw a 16-year-old girl who was not receiving any physiotherapy. So we asked the headmaster, what's going on? And she said, well, she has Rett syndrome and she's 16, so she's going to go into the 4th stage any minute now, so why bother? So of course we were very angry and we got her therapy sessions, but this is what started this research, because I knew that many girls are actually losing and regaining walking. So The present intervention is all families with individuals with Rett syndrome with independent walking were approached in Israel. The parents were asked, did your child experience any episodes of inability to independently walk? At what ages did your child did those episodes occur? What was the reason for such episodes? And how long did they last? And what was the reason independent walking was regained? And we had a list of 154 diagnosed people in Israel. We took out 11 with CDKL5. We took out 18 that we haven't seen. Actually, we haven't evaluated them yet, so we don't know their functional status. We took out 15 with contact details that were not very clear, and we took out people that we know were not independent walkers, so we ended up with 49 participants. So actually episodes of stopping and regaining walking occurred in 37 of those 49. So actually 80% of girls with Rett syndrome with independent walking are showing episodes of losing walking and regaining them. On average, if you want to be a stickler, you can say 1.9, but you can also say that on average 2 times per person. So every child with Rett syndrome who is independent walker might have 2 on average. Yeah, so there were some of them did not lose walking at all at any point, but on average 2 losses of independent walking for each child. Age, sorry to borrow. I'm sorry, I'll make it faster. Ages of losing independent walking was between 1 and 33. It was spread all around, but the mean age of losing walking and before regaining it was 11.2. So, and this is the beginning of adolescence, and we know that this is what it says in the literature, that this area here is where children with Rett syndrome actually lose their walking ability. So maybe we can, not all of them are actually losing it. Maybe some of them are just waiting to regain walking again. Duration of independent walking cessations were 180 days, so it's actually almost half a year, 6 months. But if we look into the different length of not walking, we can see that most of them, 65%, were actually less than 1 week, and only 11% were more than 6 months. But these were like 4 years, 6 years of not walking, so they influenced the mean a lot. And most of the individuals regain walking spontaneously. Those with longer duration regain walking due to intensive walking programs by the parents or by the caregivers. So it's important to keep going. And if we go into the reasons, maybe shortly, so orthopedic reasons were actually 4th of those reasons. It was people who had a fracture or a splint that was not matched, shoes that did not match. Neurological is mostly children who went to hospital who had very severe epilepsy and who were hospitalized after severe seizures, and during the stay in the hospital and a few days later they were not able to walk by themselves. Iatrogenic is mostly use of non-fitting anticonvulsive medication. Emotional, one of the children, for instance, in the research, she had I don't think you have it a lot in the United States, but in Israel we have a lot of Filipino caregivers. So this girl had a Filipino caregiver who was with her for 3 years, and she went for vacation to the Philippines. And this girl stopped walking for a month. She stopped eating. She she slept throughout the month. She lost 3 kilos, and girls with Rett syndrome, she didn't have a lot to lose from. So it was very intense. Sensory elements, I'm not going to, it's 15%, but you're going to see a woman with who stopped walking because of sensory issues, so I'm not going to elaborate on this. Physiological, for instance, we had one woman who was vocalizing a lot, so the school, the caregivers at school fed her jam and chocolate all the time, so she will not make so much noise. She got up to 90 kilos. She couldn't walk anymore, and she got the physiotherapist at the next place where she got to said that this is not going to happen on her watch, and they got her on a diet. They got 30 kilos off, and she regained walking. Also, one of the girls that we interviewed, that the families were interviewed, she stops walking every time before she gets her period, and then 3-4 days later she gets back going. Maybe the most important thing is unknown here. There's 0. So the important thing is that losing and regaining walking, independent walking, is very common phenomenon in individuals with Rett syndrome. And the thing that I've said before that it's important is in all episodes, the parents knew the reason for the cessation of independent ambulation. I mean, these are girls who do not speak, so it's not surprising, but it's kind of a prize for. It should be appreciated that the families always knew why the girls stopped walking, despite the fact that these girls could not say, I haven't been walking because my legs is cramped or something. But this is something that we should consider. If a girl is in a residential settings and the caregiving staff there doesn't know her as well as her parents, she might stop walking and end up in a wheelchair because nobody knows why she stopped walking. But I want to come up with another idea, as this phenomenon of reduced function and mobility is not only seen in girls with Rett syndrome, it's also seen in children with cerebral palsy and children with Down syndrome around the age of adolescent. And also, as far as we know, so far, there are no pathological elements detected in individuals with Rett syndrome, not in the muscles, not in the skeletal system, not in the neurological system. So there's no reason for them to lose walking during adolescence or when they become older. Nothing is happening to their system that might cause this deterioration. So actually, I'm suggesting to follow Dr. Ellison Kerr, a suggestion from 1996, and she suggested that that Rett syndrome will be defined in 3 stages actually: pre-regression, regression, and post-regression. Hanging this fourth stage, loss of acquired skill, is kind of putting it up there for. Some people might might expect this thing to happen and maybe say, okay, the child has lost walking, so there's nothing to do. She has reached the 4th stage. So the next thing I want to talk about is regaining walking ability in a woman with Rett syndrome. She was born in 1980. She had a slow yet apparently normal development up until 1 year of age. During the 2nd year of her development was halted and beginning of hand mannerism was shown, and she started walking at the age of 2 and was diagnosed with Rett syndrome at the age of 3. And as you can see, this is from her medical files when she was 22. Until 3 months ago, walking with support. Since then, an increase in spasticity leading to loss of walking ability, and a month later, does not stand, full loss of walking ability. And this is how I met her when I started working in this community housing. As you can see, she's completely fixated. And so what we started to do is we started walking drills. Okay, I started walking with her. At the beginning it was very passive, of course, and gradually it became, she participated more and more. We did independent walking. Okay, I've built this is an old Rifton pediatric walker, and I've put a regular walker on it, so she's kind of hanging on the walker, but she was able to walk this way. Gradual reduction of wheelchair usage. Okay, I've built 3 chairs like this, and one was placed near her room, one in the dining room of the residential center, and one in the daycare center. So instead of being wheeled in the wheelchair from place to place, she was actually walked from chair to chair. So she started walking more and more. And also staff guidance. Why did we need staff guidance? So this is the girl. Okay, and here you can see what happens with her is when she's moving from a sitting position to a standing position, she kind of loses her proprioceptive orientation. So at that point, I'm doing it very slowly because I want her to participate, because it helps her orient herself. Now at this point, if I leave her, she falls backwards. If I pull her forward, you see what she does? If I pull her forward, she's going backwards. I pull forward and she goes like this. So the caregivers were pulling her from a chair, and then they saw she was pulling backwards. So, but if you give her, so they stopped. But if you give her time, when she is ready, she starts to move. Oh, okay, there we go. You see, when she's ready, she starts moving. It takes her about a minute to reorganize her new posture. Okay, I'm not holding her, I'm holding her for safety, not because she needs it for walking. And here I'm just directing her back into the camera because she was going out